Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of one AMA PRA Credit 1 category. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME standards for high integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and other individuals in a position to control content for this activity. Those who have disclosed a relationship with an ineligible company are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with the ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on this screen and will be shared again at the conclusion of this webinar. By the end of this week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on the screen for your convenience. For any issues or questions regarding claiming credit, please contact education@AANS.org. Now, to get us started, I would like to introduce Dr. Gardner.
Thank you. Just a brief introduction. This is another in the series of skull-based webinars. They are partly focused on new approaches, but this one I'm especially interested in because I think this should be the future of skull-based oncology, which is really understanding the molecular and genetic underpinnings. We have a spectacular panel today. With no further ado, Sean Ross will be our moderator tonight. So, Sean, thank you.
Thank you for having us. Good evening. My name is Sean Raza. I'm the moderator for the session tonight. Just to provide some context for the session, as we all know, within skull base, we've seen tremendous evolution in terms of surgical techniques. What's happened over the last few years is our understanding of the molecular and genetic underpinnings of the different types of benign and malignant disease we treat have evolved. And as a result, we're working now towards more tailored treatment strategies. So to that end, we have really a tremendous panel lined up today, a group of individuals who really have contributed to our understanding in terms of translational research in this area. So first off, we'll have Dr. George Nunos, who's the new director of the cranial base program at UPMC, discuss the molecular classification and profiling of chordoma. Then we'll have Dr. Carl Schneiderman, a otolaryngologist and head and neck surgeon at UPMC, discuss Lutathera for olfactory neuroblastoma. And then rounding out the session will be two talks on craniopharyngiomas, Dr. Fred Barker at Harvard MGB discussing papillary craniopharyngiomas, and then Dr. Todd Hankinson at the Children's Hospital of Colorado discussing targeted therapy for adenomatous craniopharyngioma. So on that note, we'll have George start out discussing chordoma.
Well, thank you, Sean and Paul. This is an amazing series, and I've learned tremendously so far. And thank you for the opportunity. We'll discuss today something that's near and dear to my heart, which is the molecular classification of chordoma and its impact on disease understanding and treatment. So as we all know, chordomas are quite rare, and the resources associated towards its research, it's quite limited. So we don't really understand too much about it as compared to some other more common diseases. But of course, in order to be able to be effective in its treatment, we need to understand it better. We do know that the expression of brachyury, which is the T-box transcription factor, essentially something that's quite necessary for differentiation of mesoderm, and is also a regulator of notochordal formation, is essential for chordoma. And even in the latest WAJ classification, conventional chordoma is defined as the tumor that produces brachyury. This constitutes the lion's share of all chordomas, And we have two other subtypes, the dedifferentiated one, which is a mixture of conventional brachyuria expressing cells and brachyuria negative cells that resemble high-grade sarcoma. And also the poorly differentiated chordoma, SMARCB1 INI deleted one, which is usually found in younger patients. That being said, even within conventional chordoma, we see a very wide spectrum of biologic behavior, with some chordomas behaving quite more aggressively than others. And way that is, we don't really have a very good understanding of. So even though brachyuria is so essential in chordoma, there's not a lot of mutations that actually happen there. There are some somatic duplications in familial cases, and in the first attempt at the driver landscape for sporadic chordoma done by Dr. Tarpey and the Sanger Institute, we did find that there was recurrent duplications of T for brachyuria, but nothing really much else. It was also found that there was homozygous deletion of CDKN2A, mutations in the PI3K signaling pathway, and some in chromatin remodeling pathways, as well as an unusual mutation in a gene called LIST, which had to do with lysosomal trafficking, which so far actually didn't pan out to have anything too important. But in general, there was an overall low mutational burden in these tumors. There's mounting evidence that skull-based chordomas and spinal chordomas are genetically different. And we also don't know if they're part of a continuum where they start as an indolent lesion and they eventually turn into something more malignant. Dr. Raza here and his group very eloquently put together the prognostic biomarkers that predict both progression-free survival as well as overall survival, and other groups, segregated them into clusters affecting cell cycle, the microenvironment, or tumor immunology. One of our goals was actually to find biomarkers that would individualize care and guide us in how to manage these tumors. For example, which tumors actually need to be radiated, which is something that is associated with potential morbidity, or which tumors are not going to be very good surgical candidates because they're going to be very aggressive. So those may be tumors, for example, that go straight to neoadjuvant therapy in one of the trials. So in brief, this was our original work looking at a number of different factors in the chordomas that we had available at the time. And we looked at progression-free survival after surgery as well as progression-free survival after radiation. We also found that the markers, particularly with FISH, the percent of the tumor cells that actually harbored these mutations, they were incrementally predictive. And we again looked at that both after surgery as well as radiation, but when placed in a multivariate analysis, we found that this 9p21 deletions with p16 and 1p36 drove a lot of the mitotic activity, rendering the Ki-67 actually no further significant. And when we also attempted to create a molecular prognostication calculator based on these deletions, which were predictive over a wide range of prognosis. And we made some recommendations at the time, but however, we didn't have data on the resection rates. They went back and added that data with more cases. Indeed, even in the cases where we had a gross total resection, the groups were quite prognostic of progression-free survival and with a very wide range of prognosis. So in all tumors, we found that a gross total resection actually significantly affected prognosis. But there was difference of whether adding radiation therapy made a meaningful change. For example, in group C, which is the worst prognosis patients, adding radiation therapy significantly improved survival. So we recommended that this is done essentially universally. In group B tumors, this only made a difference, radiation made a difference if complete resection was not possible. Whereas if you were able to get a complete resection, it didn't seem to affect survival much. Interestingly, group A tumors were phenotypically different in that they were usually found in younger patients. They were smaller tumors and many times asymptomatic, and therefore almost essentially all of them had complete resections. And in this group, we did not find that adding radiation actually made a difference. So essentially, we created an algorithm that allowed us to spare radiation in group A and group B tumors with complete resections. So we're finishing up about a 5-year endeavor in a multi-institutional project for, again, redefining how we best individualize treatment for these tumors. Interestingly, Dr. Bai's group for Beijing found that the 9p21 deletions were differentially predictive than the actual CDKN2A mutations. So the whole area in that part of the chromosome works synergistically in order to affect the disease prognosis. And we worked with Dr. Bovy from Leiden University to essentially create an NGS surrogate of this entire locus of both 9p as well as 1p36. Interestingly, this can also be tied to radiomics, and Dr. Colin helped us do that by following her pipelines and segmenting the tumors, both the T1 sequences as well as the T1 with contrast. We're able to tie both the progression-free survival, but also some of the biomarkers with specific radiomic markers. Circulating tumor DNA, I believe, is going to be quite more significant in the treatment of chordoma. And in fact, Dr. Zade had incorporated that in subclassifying chordomas into 2 clusters using plasma. The Chordoma Foundation has been integral in focusing all efforts. It has been integral in creating a centralized biospecimen tissue bank, and identifying therapeutic targets. For example, CD4 and 6 inhibitors, palbociclib, has been in clinical trials and is promising, as well as immunotherapy. And then more directed therapies targeted at brachyury has been essential also in developing cell lines and xenografts and transition of preclinical drug screening programs into actual trials. There's a number of trials that were completed already. Some of them were including the chordomas as part of a more wide inclusion criteria for other cases as well. And the data are available on the Chordoma Foundation website. There are also chordoma-specific trials for adult patients as well as pediatrics and young adults. So with that, we'll conclude that chordoma is a diverse disease pathology, and understanding its molecular underpinnings allows us to better prognosticate, but also individualize care. And of course, the further we understand, we will hopefully be able to better create targeted and more effective treatments. So thank you very much.
George, tremendous work, and thanks for that talk. We'll certainly have some cases and discussion points towards the end. Carl, would you like to go ahead and share your slides and discuss
Sure.
Lutathera for aesthesia?
Thank you. So it's a pleasure to speak with you tonight on the use of dotatate imaging and Lutathera treatment for olfactory neuroblastoma. And my disclosures are not relevant to this presentation. So some of the challenges that we still face with olfactory neuroblastoma, one is understaging due to the lack of effective imaging modalities. And this can result in undertreatment if we're not recognizing early subclinical disease, but could also result in overtreatment if you're treating patients with for possible disease when they don't have it. The other problem we have is very delayed recurrence. You know, it's not unusual to have patients recur more than 10 years after treatment. And so because of this, we really have less effective treatments because if we don't have good outcomes data. And if we're treating, and also the treatments that we use have significant morbidity if we are over-treating people. In regards to staging, standard imaging consists of CT and MRI. PET scans have been used to better differentiate, especially in the N0 neck, looking for evidence of pathologic cervical metastases. And FDG PET has been used, but in comparison to dotatate, which specifically targets neuroendocrine tumors via the SSTR2 receptor, FDG is not as sensitive as dotatate. And here's an example of a patient imaged with dotatate. You can see the submental lymphadenopathy shows up very well, but in contrast, there are also some retropharyngeal lymph nodes which are not apparent on MRI, but are very brightly enhancing with dotatate. And that's been my experience as well. I've had patients with negative FDG PET scans, negative MRI, but very obvious metastases with dotatate. And so really that has become our new standard. There are different agents that are used for imaging. Our institution has switched to instead of gallium as an imaging agent, we use copper-64, and it has an advantage of a longer half-life, which makes it much more convenient for scheduling dosing of patients. Although there are some concerns that it may result in a higher radiation dose, but there also is some evidence that it may have a higher detection rate of metastases. So recently we put together a consensus statement reviewing the literature on the use of dotatate imaging and really making a case for why we should be using dotatate PET over FDG PET for proper staging of our patients. And so I think that should be the new gold standard for anybody presenting with an olfactory neuroblastoma. One problem, of course, is that insurance companies don't want to pay for it at this point. Moving on to treatment strategies for recurrent olfactory neuroblastoma, recently we looked at how we treat recurrent disease. That's something that's been ignored in the literature. And the recurrence rates, if you follow patients long enough, are actually high, over 30%. And so we divided these into local, regional, distant intracranial, and distant extracranial metastases. And here you can see the different types of treatments that were used for treatment of recurrences in these different sites. Most recurrences tend to be local and regional, and from there they can go on to have distant metastases. And then in a subpopulation of these patients, because they had failed at all other therapies, we experimented with the use of radioligand therapy. So this is based on the expression of the somatostatin receptor 2 by most neuroendocrine tumors. In particular, olfactory neuroblastomas almost uniformly express SSTR2. And so this can be targeted with a somatostatin analog that is chelated to a radionuclide. And so there's a therapeutic FDA-approved agent called lutetium dotatate, or otherwise known as Lutathera, which is approved for the treatment of advanced neuroendocrine tumors of the GI tract, has been used for meningiomas, and then off-label, we've started looking at it for the treatment of olfactory neuroblastoma. There isn't much literature out there, some isolated case reports, a very small series. And then we've looked at our own experience with only 6 patients treated at our institution. And we defined a complete course of therapy as 4 infusions of Lutathera and had pre and post-operative imaging, of course, to assess response. And so here are those 6 patients. You can see that multiple sites of recurrence, both local, regional, and distant intracranial. And all of our patients uniformly express SSTR2. Hyams grade has not been very useful, most often because it really hasn't been validated for recurrent disease, so it's not routinely assessed in these patients. This therapy is not without toxicity, however, mostly bone marrow suppression. Patients may develop a myelodysplastic syndrome, You can see one of our patients had to interrupt treatment during a second course of therapy due to thrombocytopenia and anemia. Other than that, toxicities were generally low and very well tolerated. And here you can see, starting with the preoperative or pre-treatment values, you can see how platelet counts, hemoglobin levels, and white blood cell counts all decline with therapy. But it is quite variable between patients, but they do need to be monitored carefully during therapy. Most importantly, we have seen significant responses. Nobody's been cured of their disease, but we've seen partial responses. And you can see three sort of dramatic examples here. The first one with a large parapharyngeal space mass that had a marked reduction with the use of Lutathera. Another parotid metastasis, and then also someone with cavernous sinus disease. So significant response. And some of these patients have remained stable, but all patients have been alive with disease at last follow-up. One patient died from a secondary radiation-induced sarcoma from prior radiation therapy, not from Lutathera. So in conclusion, Lutathera therapy is generally well tolerated, but there is a risk of myelodysplastic syndrome. Preliminary data shows a fairly good tumor response, and patients have mostly had stable disease following therapy without complete response. And this is in agreement with our limited literature out there. MD Anderson has a larger series of patients with similar results to our experience. But we really haven't defined the optimal treatment protocol. We don't know how durable these responses will be. But this does offer an opportunity for palliative treatment as well as attempts to try to control the disease. There are many unanswered questions, duration of response, prognostic predictors. I think the most intriguing possibility is the possibility of intervening for subclinical disease early in the course of therapy. So if we can identify patients at presentation who are in a high-risk group for local recurrence or distant dural metastases, this is the ideal patient population where we might want to consider preemptive use of Lutathera to target this subclinical disease. And there are other radioligands out there that we should be aware of. Here's an example of a alpha emitting particle, a lead agent, which may have advantages over Lutathera and other beta emitting radionuclides. So it's an exciting area. I think this is because of the small numbers of patients that we have. The only way we're going to answer these questions is through collaboration. So the NASBS encourages you to submit any cases you may have so that we can combine our series and answer these questions. And for those of you who are going to the ESBS meeting in Zagreb, I hope to see you there. Thank you very much.
Thanks so much, Carl. Definitely several good discussion points to cover later on. Fred, would you like to share your slides for the papillary craniopharyngioma talk?
Yes. Okay, here we go. You seeing that?
Yeah, we're seeing your slide deck. Yep, there we go.
Okay, so this is a quick talk about papillary craniopharyngioma. Most of the work that I'm going to present here was done by my colleague Priscilla Brastianos, who's here at Mass General, one of the neuro-oncologists here with me in the Brain Tumor Center. So craniopharyngioma, I know there are people who enjoy operating on these. I never did, but this is contemporary results from 14 major U.S. centers. It's often said that a gross total resection of craniopharyngioma is the best treatment, but that appears only to be possible half the time, even in experienced hands. And the radiation treatment for subtotal resections is associated with significant complications that are generally lifelong, consisting of visual deficits, endocrine deficits, neurological problems, and imperfect progression-free survival. In addition, if you follow patients long enough, most of them have significant lifelong problems with hormone deficiencies, visual disturbance, hypothalamic dysfunction, obesity, failure to return to work, and a long list of things that we're all familiar with. So that long-term survival is great. Long-term failures are infrequent, but there's a lot of problem with morbidity of the tumor itself, and if we're honest, morbidity of treatment. So Priscilla, when she was a fellow in neuro-oncology, worked on molecular defects in adamantinomatous and papillary craniopharyngiomas at Mass General Brigham, and found that about 95% of papillary craniopharyngiomas by classical histology had the V600E mutation in the BRAF gene, which is a lucky break for us because good treatments for that had been developed for the melanoma market, which is economically much more interesting to drug companies because there are so many more patients. In addition, there are very few other driver mutations in papillary craniopharyngioma, unlike the situation, for instance, with glioblastoma, which is a combination of about 1,000 different tumors and very difficult to handle with targeted treatment. So together, we put together a phase 2 trial of BRAF MEK inhibition, combined inhibition in newly diagnosed papillary craniopharyngiomas through the Alliance Cancer Cooperative Group, which is NCI funded. The target was 16 patients enrolled in each of 2 arms, one being newly diagnosed craniopharyngiomas that had a molecular diagnosis but had not had radiation treatment, and the second was tumors that had recurred after radiation. Primary endpoint was imaging response, but we had secondary endpoints that I'll show you in a minute. The long and the short of it is every patient who received the drugs for more than a week had a major response. The only patient who received 8 days of therapy had an allergy that was ascribed to the drugs. Other volumetric responses averaged 91%, with a range extending up to 99%. These responses occurred both in the solid portion of the tumor by imaging and in the cystic portion. Toxicity was modest and reversible. Here's what a 95% response looks like. Here's the residual tumor after surgery, and here's what was left after the treatment. So we didn't give this 100%, but it's 95. We built into the study from the beginning an endpoint of whether or not radiation fields would be positively affected by the volumetric response, because, to be honest, a volumetric response in targeted treatment is not that interesting if it doesn't actually produce a benefit for the patient. So 8 out of 14 tumors that abutted the optic chiasm before treatment were separated from the chiasm after treatment, and the gross tumor volume was reduced by 91%. And we published this in the New England Journal a couple of years ago now. This is a French cohort that was published last year in the European Journal of Endocrinology. I believe they treated 14 patients with very similar results. So this brings up the possibility of neoadjuvant therapy. So we're not very familiar with this in neurosurgery, but there are many other areas where tumors, malignant tumors, occur adjacent to functionally important tissue. For example, laryngeal function in head and neck cancer, where neoadjuvant therapy has been standard for some time, rectal cancer, esophageal cancer, limb salvage, and soft tissue sarcoma treatment, and so on. We just don't see much of it in neurosurgery or skull-based surgery more generally. So we asked for the next step, is it possible that we could treat patients before surgery? Now, right now, in order to get the insurance company to pay for the drugs, you need a molecular diagnosis. That's probably our major hurdle right now, because we have good radiological diagnosis of this. We only had 5 out of 32 blood samples from the Alliance protocol that were positive for the V600E mutation. And we haven't analyzed these fully yet, but the quality of the samples and the requirement for transport our limitations on this. So far, we have not seen cell-free DNA in the CSF, with one exception, which turned out to be a third ventricular metastatic melanoma from an axillary primary. We have had one positive cyst fluid result, but cyst fluid isn't that interesting because you might as well get a biopsy. So after treatment starts, we have seen cell-free DNA, but of course, by then the game is over. We developed, as soon as we saw what was going on with this, we did our best to work with standard MRI and CT and develop a classification system to predict papillary histology. Age greater than 18, no calcification on CT, and a supradiaphragmatic tumor. We're 89% specific, again, with a high positive predictive value on an external validation set. So the question comes up whether or not you could do an endoscopic biopsy with or without cyst drainage, without a resection, transventricularly, and then use BRAF-MEK, and then figure out what to do next. So these are the two ways you can get at this to get a molecular diagnosis. Here's our positive predictor value in an external cohort, which was 83%, just a schematic of the transventricular approach to a biopsy. So far, we have 6 patients. The 6th is too early to report. These are results put together by Pamela Jones, who's the one doing the surgery on these here. All 5 patients have tolerated treatment more or less well. This is the volumetric response on these 5 patients, including one patient who only had the drugs for 1 month. 90% response was the average, with sustained durable responses in all 5 of the patients. Typical hospitalization for these patients is 1 day. So this systematic review put together 11 cases similarly treated from the literature, with a median duration of treatment of 6 months and a median volumetric response of 90%. Is this all you need to do? So what about that patient who just had that little speck of enhancement? We're all familiar with tumors like hemangioblastoma, where the majority of the enhancing volume is actually stromal cells and not tumor cells. We've only seen one patient who had surgery after BRAF-MEK, and that patient had a gross residual disease. He had only had treatment for 1 month. There were no resistance mutations, but we just don't know what to do with this situation. The standard in other fields is to treat to best response plus 2 cycles, and then either consolidate or observe. So far, we don't have the results yet from the Alliance trial thoroughly investigated, but I believe there were a half dozen or so patients who refused radiation or surgery after their treatment was completed. And so far, I believe we only know about 1 recurrence, and that patient, the recurrent tumor shrank again when the BRAF-MEK was started, and then he had consolidation with radiation. So I think that this is an exciting pathway for us to go down. We're working on ways of assessing this more formally in a larger group, but I think the future for this disease is for surgery to play a much less important role, and for BRAF-MEK to carry the ball until radiation, if necessary, for consolidation. So that's all I had to say tonight. Thank you very much for the opportunity.
Thank you, Fred. Todd, would you like to share your slides?
Sure. Sorry, let's get back to the beginning here.
While Todd's getting that ready, I'll just mention that Priscilla is going to report the results of the recurrent arm, which only accrued 5 patients at SNO this week in Honolulu.
Cool. Can you guys see this okay?
Yes, we can.
Okay, so I'll just talk a little bit about some of the molecular background that we know of related to adamantinomatous cranio. And I think sort of one of the big takeaways is that, we're way behind where we are in terms of papillary cranio. And really, none of the treatments I'm talking about are really approaching standard at all yet, whereas I think we're getting much closer to that with the papillaries. So the most important thing, I think, to really understand when you're thinking about the basic biology of these tumors is the germ cell layers that they derive from and the anatomical location at this junction of oral ectoderm and neuroectoderm, and the fact that that has implications for the competence of the blood-brain barrier at the site of these tumors, and also the really substantial cellular heterogeneity that we see. The multiple different cell types that seem to pretty clearly be interacting through paracrine signaling has significant implications on what we do in terms of thinking of therapeutic vulnerabilities for these. And not unlike papillary cranios, there's really sort of one canonical genomic aberration in these tumors. And there's been a lot of debate about how often it's present, but I think that's mostly related to sampling error and depth of sequencing. And probably every one of these tumors does have a beta-catenin mutation in the CTNNB1 gene in the epithelial cell subpopulation of the tumor. So they've all got an epithelial cell component, and those cells probably all harbor a beta-catenin mutation. And what that does is prevents the BCAT from being able to be broken down through normal pathways, and that leads to accumulation in some cells, intranuclear accumulation, where it acts as a transcription factor and upregulates Wnt pathway signaling. And we don't know completely how that leads to the other things that we see with regard to these tumors, but it's certainly suspicious that that's a starting point. And just to sort of reinforce the idea of the histological heterogeneity that these tumors exhibit, this is just imaging mass cytometry. So it's effectively kind of like sophisticated immunofluorescence. So these are protein expression that you see here. And you can just see that there are many different cell types admixed in different ways, in addition to complex extracellular matrix structures like collagen and vimentin. And so understanding the way that these different cell populations and ECM components relate to one another is really critical for how we address these tumors. And it's an area where we're sort of actively doing work in the lab and with some of our collaborators. So right now, there are 3 clinical trials that are open that are basically designed to address sort of like rational targets in craniopharyngioma. And so I'll just kind of walk through the basics of the biological rationale for each one of them, and then summarize what they are. So the first one tests an IL-6 receptor inhibitor, tocilizumab, which is a monoclonal antibody. And this is really important as it relates to the blood-brain barrier question, which I'll bring up in a second. But this came originally from work looking at the transcriptome of these tumors that showed exceptionally high levels of IL-6 receptor, both in the solid components of the tumor and IL-6 in the cyst components of the tumor. And that was confirmed a couple of different ways. And then we did a phase 0 trial that basically delivered a dose of tocilizumab up front for patients who needed surgery, and then was able to identify that the drug got to the tumor, which implied that the blood-brain barrier, while not completely incompetent, was certainly compromised around these tumors. And that has implications for the molecules that we can use to potentially treat them with systemic therapy, because we can use things that otherwise we might not be able to use if there was a completely normal blood-brain barrier present. And then there were a couple of case reports where patients were treated on a compassionate use basis with combinations of either tocilizumab and bevacizumab or tocilizumab alone. And these demonstrated control of either recalcitrant tumors or a decrease in the size of a relatively newly diagnosed tumor. So this was the rationale for tocilizumab, and that's one of the drugs that's being treated right now in an initial being used right now in an initial open label phase 2 study. Another one of the studies that is open right now is investigating binimetinib in a similar way. Binimetinib is a MEK inhibitor, and the work that underlies this largely came out of J.P. Martinez-Barbera's lab at University College London, and they use a genetically engineered mouse model in combination with some short-term slice culture models from human tissue. And what they were able to demonstrate, and this image just sort of shows the tissue from human tumors, but that there was a dose-dependent response to treatment with trametinib, which is another MEK inhibitor besides different from binimetinib. That basically showed decreased cellular proliferation and increased cell death when delivered to the tumors. And additionally, there was other work that was done from Song Tao Chi's group in China that similarly demonstrated upregulation of the MAP kinase pathway and macrophage mediated phagocytosis, which is something that we've been working on a lot in our lab as well. And then there have been a couple of other substantial papers that looked both at proteomics of these tumors and a case report out of NYU that showed with binimetinib a recalcitrant tumor responding to systemic therapy. This is also justification for the use of tovorafenib, which is being used in the 3rd clinical trial that I'll kind of detail here in a second. That's being done through the Pacific Pediatric Neuro-Oncology Consortium, and that's a pan-RAF inhibitor, so it's kind of one step up in the pathway from the MEK inhibitors, but similarly, it's being used right now as a single agent. So the 3 trials that are open now, these are each multi-center consortium-based international trials. So the 2 trials that are being run through Connect are open primarily in North America and Australia. As I mentioned, one of them uses tocilizumab. It's an IV drug that's given on a Q2-week basis, targets the IL-6 receptor. The second one is using binimetinib, which is an oral agent. So that one has some advantages in terms of drug delivery. And that one's basically given twice a day through the course of therapy. PNOC trial, initially it started off as a combination trial, which was had a pretty cool design, which was a treat biopsy treat design where patients who needed surgery were given drug, had their surgery and then the tissue was assessed with various parameters, and then were randomized to either go on nivolumab, tovorafenib, or the combination. There were some side effects that were attributed to nivolumab, which is a T-cell dependent checkpoint inhibitor, a PD-1 inhibitor, and therefore that was dropped from the trial. And so now it's just a single agent tovorafenib trial, and that's enrolling now as well at multiple centers. And so now that's got a similar design, but everybody goes on the tovorafenib arm. So these are the 3 trials that are open now. The age span that they cover goes from 1 year of age up to 39. So we do have patients that are in that sort of young adulthood range who are potentially eligible for these trials. But I think that these are certainly earlier on in terms of their effectiveness and our understanding of the biology than what we see with the papillary craniopharyngioma work that Dr. Barker presented a second ago. So just in sort of quick summary, I still think that standard treatment for adamantinomatous cranio is maximal safe resection and radiation. And there are a number of pathways. I just detailed the ones that are in active clinical trials. There are a few that we're still sort of investigating a little more in the preclinical space, but I think should be things that we should be able to leverage in the next sort of round of clinical trials. And as we get through the 3 that are currently open, we're hoping to enroll a little bit larger trial or open a little bit larger trial that's going to be able to enroll through multiple different arms that we can quickly move through in terms of determining things that have early signal for response or not. And that's pretty much what I got. Thank you.
Thank you, Todd. We have about 10, 15 minutes left. So what I do is I have 3 cases. I'm hoping to sort of bring us some practical aspects of some of the concepts our panelists have highlighted here. And so I've got a chordoma, an olfactory, and then a craniopharyngioma. George, are you on the line?
Yes, I'm here.
All right. So this is a patient that I saw a while ago as a second opinion. Younger patient, less than 35, relatively asymptomatic, was just having some vague neck pain, and was found to have this low clival mass with involvement of the anterior arch of C1 and a little bit of the left occipital condyle there, and had a good endonasal resection on the outside. And you can see the postoperative scans on the bottom there. And notably on the bottom right there, you can see that there is that sort of low volume residual disease just adjacent to the dens, medial to the condyle, and tucked away sort of in that potential space with the craniocervical junction ligaments. So putting together the beautiful work that your guys' group has done, looking at 1p36 and 9p21 status, how would you think through the management of this residual disease in this essentially newly diagnosed young patient? Because on one hand, essentially it's resectable. You can get a gross total resection, but it comes at the cost of CCJ instability and needing an OC fusion. The concern, of course, is with these craniocervical junction tumors, if they progress and gain access to the epidural venous plexus, there's always that concern of sort of epidural spread down the road. On the other hand, to put someone through an OC fusion for such low volume disease, that's always a big sort of quality of life consideration. So if this was group A versus B versus C, how would you think about this residual disease?
So I think that's a very good question, Sean, and very nicely chosen case that you have here. It's quite a bit of a conundrum. So the data that we have obviously is that if it's a grade A or group A or group B, if you're able to get complete resection, you're sparing someone radiation. But I think the question comes here, what is more morbid for someone? Is that radiation or obviously fusion? And I think it does come down to a discussion with the patient. Also, these craniocervical junctions, chordomas, are a little bit different beast in many regards. Partly, it's probably biological, but also anatomical in that they have all these little pockets of disease that are there. And, it depends also on the impression that someone has from the surgery itself. So if it's just a little area there, but if during surgery you had an impression that, of course, there's that disease that I see on the MRI there's a little nugget there, but at the same time, you probably have microscopic disease that you don't feel so good about, as opposed to, just a central clival lesion where you went around it quite a bit and found more normal appearing bone. I think that's someone that probably would skew towards radiation. If it's, let's say a group B or a group C tumor. If it's a group A, which usually these craniocervical junction tumors are not. As I mentioned before, usually group A ones are the ones that is somewhere between a chordosis or a benign notochordal tumor and a chordoma, where there's smaller tumors that pretty much everyone has a gross total resection. So it's unlikely that it's going to be a group A tumor. So I think at the end of the day, it does come down to a discussion with the patient about the pros and cons of each one. But at the end of the day, I think going for a gross total resection, if you truly feel that that's just the only spot, I think is not reasonable. There certainly is morbidity to each one.
No, that's great points. And I know this hasn't been studied, but I guess what your gut feeling in terms of, the types of postoperative radiation therapy, could that be tailored based on the grouping? Because it's certainly right, the dose. I mean, traditionally we've thought about, if we're going to go down the road of radiation, is high dose, proton typically independent of sort of biology, but it clearly behaves across the spectrum. So there's probably room for dosing and clinical target volume also.
Yeah, I think that's a great point. I think that's a less well elucidated discussion, honestly, because even if you have a discussion with some of the radiation oncologists that do proton beam, it does depend at the end of the day of the surgical outcome. So if you're treating a large area, obviously the proton beam allows you to give that higher dose at that larger area. But if you have a small area like that, the bioefficacy actually of photon-based radiosurgery, if you get a 1 fraction at let's say 20 gray, that goes a lot farther than actual proton beam. And again, been in parts of a number of different forums with radiation oncologists sort of just arguing about this. But it is a great question. I don't think that we've studied that in that detail. I think you and I are a part of this multi-center group that perhaps may allow us with more numbers to elucidate that a little further. But so far we don't really have the data. I think it comes down to essentially the volume of disease and what you're treating in terms of what kind of treatment you choose.
Thanks, George. I know we can go on forever on this case. So in the interest of time, I'll go on to the next case. Carl, are you there?
Yes, I am.
So this is a patient of mine that I treated quite some time ago. Himes 2, did an endoscopic, craniofacial with negative margins, and did the standard, radiation post-op to the skull base and to the neck. It was a N0 neck at that time, so elective neck radiation therapy. And of course, you have, clear scans for quite some time, and sort of tying into what you brought up is, 7 years post-treatment, get a dotatate. And on the MR and the dotatate, what we find is non-contiguous dural mets. So outside the radiation field, not contiguous with the original site. Bony skull base mets, again, not even close to the original site, and systemic mets, and treated with Lutathera. because of the somatostatin expression. And then, post Lutathera, interestingly enough, saw a good response on the dotatate PET. Interestingly enough, though, one of the intracranial sites progressed significantly. And I apologize, the dotatate PET, the left and right are flipped off on the left one here. So here had a right frontotemporal met, dural, epidural in nature, bony disease, and then you can see some subgaleal disease extension. And ultimately resected it. Now, I guess sort of your thoughts on this, in the sense that when you look at the neuroendocrine population and reports with Lutathera, there is some discussion about intratumoral heterogeneity with somatostatin expression. And if you're giving a somatostatin targeted radionuclide, the chances of success or response based on somatostatin expression, because the assumption is that it's really not uniform throughout. I guess I'm curious to see, have you had experiences like this for patients with sort of metastatic disease, partial response to Lutathera, where some sites have responded pretty well and other sites have progressed? And how do you typically manage that in the post-Lutathera setting?
Boy, I mean, it's a very unusual case you're presenting here, but I don't think we have the data yet. In the studies we've done looking at SSTR2 expression, it's been pretty uniform. You see some heterogeneity in tumors, but that really doesn't correlate well with the imaging characteristics. And so I don't think we can rely too much on the SSTR2 levels for prognosis at this point. I think what this case highlights is that by the time someone has multiple recurrences and metastases, we've sort of lost the battle already. And even though these therapies show some promise, they're of limited value. I think we need to refocus on patients at presentation and really do a better job of defining who's at high risk, and can we target subclinical low volume disease when the Lutathera is more likely to be effective. I think that's where these drugs show the most promise.
It was interesting with this case, just because of sort of this discordant response. When I was just going through the neuroendocrine literature, they talk about getting like an FDG PET and matching that with the dotatate PET to see if there's match. And for this patient, I got an FDG PET because of the progression of the intracranial disease, and there was definitely a mismatch. So the bony disease and the subgaleal disease didn't light up on the dotatate as much, but it really lit up on the FDG PET. I guess the other question that comes up is really when you're dealing with like these post-Lutathera recurrences and you take it out in terms of technically re-irradiation afterwards, and it seems like there's a pretty steep fall off with the Lutathera. So then you can still go ahead with conventional radiation if you have someone that's failed Lutathera.
Absolutely. I mean, an alternative is to use radiosurgery, standard techniques for targeting lesions. In isolated distant mets, there's a role for surgery. But everybody's experience is too limited at this point to really answer these questions.
It'd be interesting to see how the story grows over time.
Yes, I mean, I think with new radioligands that are more effective and earlier treatment, I think this really could be a game changer. The problem with looking at the literature, as I alluded to before, is that the median follow-up is only about 5 years, and we have patients that are recurring 10, 15 years after treatment. So unless we have that long-term follow-up, we really don't know. We don't have a good idea of prognostic indicators, and we don't know how effective our therapies are.
And also a point that you brought up in your talk about the Hyams grading, that theoretically Hyams 2, not that bad, and then you see something like this happen with the patient who started out with the Hyams 2 aesthesia, and so realize you can never be caught off guard and have to have your sort of be suspicious at all times.
Yes.
And then my third case, would love Fred and Todd's thoughts. And actually, before we start, Fred, I was hoping to have you comment on for the audience about sort of the rationale behind the dual sort of MEK BRAF inhibitor therapy versus sort of monotherapy with the BRAF inhibitor, just like explaining the scientific rationale.
It's based
For
on the
cranios.
melanoma literature. It couple things. One is BRAF alone, you get a bunch of squamous cell skin cancers over time, neoplasia. And the second is to try to shut down resistance mutations. In the melanoma world, BRAF/MEK doesn't work forever. The real long-term responses are from immunotherapy, and I don't think we really know the 10-year toxicity of BRAF/MEK inhibition. Patients don't like it. They don't want to be on it. Nobody's going to take this for life. So it's not ideal from that standpoint, and probably never will be. But over the medium term, I think it is more effective, first of all. Secondly, less induction of new cancers, and third, less resistance.
Fred, can I
Thanks
just
for
ask
that.
you real quick, Sean? Fred, how much
Yeah, go ahead.
resistance do you guys see in patients who have responded really dramatically, but then had to come off therapy after a relatively prolonged period of time?
I missed the first part of your question. You're asking about recurrence, or?
Yeah, or just like rebound if they have just a little bit of tumor and then they have to come off dual agent therapy.
Well, I mean, I think that to some degree, it's kind of conditioned on what the patients are willing to have. And so this protocol was written so that every patient would get either a second look surgery or radiation after 4 months of treatment. And patients were just basically refusing. They said, we don't want radiation, we don't want surgery. So this is not the way we designed it. So it's not been entirely under our control, but it's 5 years since the protocol was over. So the fact that we haven't heard about a lot of recurrences in patients who chose just to go on to observation may translate to 5-year results. And we're looking into that actively now. I don't think that it is like, I don't know, bevacizumab perhaps, where you get a rebound where a residual tumor actually enlarges rapidly. But in general, patients with residual tumor that is grossly evident have gone on to radiation. I don't know, when I was a resident, Nick Zervis, who must have had some bad experiences, said that you had to get going with radiation within a few weeks of a subtotal resection of a craniopharyngioma, or the cysts would come back very rapidly. And I have to say, you do see that sometimes, but the only patient that I know of who has gone on to a second course of treatment for regrowth of tumor had an equivalent response the second time around, and then got radiation to consolidate it.
Yeah, that's really useful to know too, that you can rescue them.
Yeah,
Sorry, Sean,
certainly worth doing. Yeah.
Yeah.
No, it's a great question. I'm getting messages now to, I guess, wrap up the session. So let me just wrap up this case, but I definitely do want Fred and Todd, your thoughts on this case. So 40-year-old, you can see with this cystic with a small nodule, craniopharyngioma, mainly infrachiasmatic in nature. She was operated on the outside by a transcranial approach. It's horizontal, and you can see this is the post-op scan. Essentially, the cyst was collapsed, but in the midst of that, they managed to biopsy the tumor as a papillary cranio. And at the outside hospital, they started her on a combo MEK and BRAF inhibitor. So started on that and had a good response. And throughout this, her visual functions improved. She's got intact pituitary gland function. And at this point, sort of came for a second opinion. And in the midst of sort of figuring out what to do with her, she experienced skin toxicity with the combo therapy and then came off of it. And so 3 months off of therapy, just a small little nodule here. Again, visually okay, and then intact pituitary gland function. So the question is really, at this point, after having had a good response to the BRAF/MEK inhibitor, clinically doing okay with the scan, what would you offer this patient?
I think it would depend on the nature of the toxicity, how bad it was, and whether it was attributed to one of the two drugs. I think if barring that, if it had just been stopped because the doctors stopped it, I think you would propose going back on it for a short period of time and then giving radiation to any residual visible target. This is a pretty small target for something like radiosurgery now, and you could make an equally good case, I think, for just treating it now without risking some kind of really horrible skin toxicity from restarting the drugs.
Yeah.
Great.
Yeah, I mean, I
Todd?
kind of want to know. Yeah, I talked to the radoncs about what the tolerance of the optic chiasm is for radiosurgery at a lesion in that particular location, and what the risk of endocrinopathies are going to be. But I agree. I think this is something that if the toxicities are low enough, it's amenable to that, especially if she had trouble with a dual agent ultimately because of her skin toxicity.
Fantastic. On that note, just want to open the floor to any last minute questions before I get booted off. All right. Well, thank you all to our panelists. I know it's a lot to cover in such a short amount of time, and I'm sure many folks are going to watch the webinar after the fact and probably reach out with questions. And then thank you to the AANS for helping organize, and of course the tumor section. So it's been a good hour, and thank you all so much.
Thank you.
Thank you.
Thanks,
Thank you.
everybody.
Good night.
Thanks, everybody. Great talk.